Good morning. Welcome to ECG's webinar covering the key trends impacting pediatric healthcare. My name is Clark Boslett and I'm an associate principal at ECG, and I'm pleased to be your moderator for today's session. The children's healthcare landscape faces unique challenges and feels the impact of regulatory, market forces, and more recently, COVID-related forces differently than adult-oriented groups and systems. Understanding these pediatric-specific trends within the framework of the larger healthcare industry is essential to positioning and tactically addressing factors today. During today's program, we will discuss the trends and the impact of these factors are likely to have on standalone children's hospitals, pediatric provider groups, and systems with a critical mass of pediatric offerings. We will also review the strategic, financial, and operational approaches that organizations, both academic and non-academic, can adopt to navigate this quickly shifting market in a manner that ensures their financial viability and mission imperatives. Before we begin the formal webinar, let's go over a few details. Today's program will be 60 minutes in length. There will be about 45 minutes of presentation, and we'll make sure to leave about 10 minutes for questions and answers from the audience. Everyone should have received a copy of the session handout, but if you were a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them in the questions pane on your screen at any time, and we will address them at the end of the formal program. If we are unable to answer all of today's questions, we will absolutely follow up with you after the session. And finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete this survey. For each completed survey, ECG will make a commitment to donate $5 to Doctors Without Borders. Now let's meet today's speakers. Steve McMillan is a senior manager with ECG, and his ability to blend a granular understanding of data with a big picture mentality helps his clients gain a comprehensive understanding of their challenges and make informed decisions that result in successful outcomes. Steve has an established track record of increasing operating efficiency and improving patient access, and his clients value his solutions for generating revenue and improving cost savings. His experience in patient access, ambulatory operations, patient engagement and satisfaction, contact centers, and financial outcomes positions him to address a wide variety of challenges facing physician groups, hospitals, and health systems today. Welcome, Steve.
Thanks, Clark. I'm excited to be here.
Very good. Our second panelist is Evan Lynch-Throne, who's an associate principal based in ECG's Boston office and is a member of the Academic Healthcare Division and the Children's Service Line. Evan is regularly called upon to assist children's hospitals and AMCs with complex and politically charged initiatives in areas such as physician hospital integration, partnership planning, and faculty practice organizational design. Welcome, Evan.
Thanks, Clark. I appreciate it.
And finally, Angie Collins is a manager at ECG, where she conducts ECG's pediatric subspecialty physician and APP compensation survey, and is integral to ECG's other proprietary research efforts. She's been instrumental in expanding ECG surveys, which are now recognized as the most comprehensive source of provider performance benchmarks in the market, and her work informs analysis on key client efforts. Angie brings her experience with client projects to her survey analysis to help identify key trends and offer survey members meaningful insights. Welcome, Angie.
Thank you so much, Clark.
All right, we'll go ahead and get started here. I'll say just a few words before handing it over to Steve. Very quickly, on slide 7, it's impossible to frame any discussion of current pediatric market trends without acknowledging the broad impact of COVID-19 this year. The pandemic has had clinical, financial, and operational implications for children's hospitals and medical groups as systems have adapted on the fly to a complete upheaval of norms. If you're like me, you're fast becoming an armchair infectious disease specialist, and the financial implications have begun to mirror the medical symptoms as we begin to accept the concept of long COVID. It's increasingly clear that there'll be no flipping the switch back to normal, as the shifts in volumes in care settings have been far more protracted than we first thought. On this slide, we've highlighted the heightened impact on visit reductions for pediatrics, which lagged well below their adult cohort and especially low for the youngest children. Pediatric ED volumes in many markets have been as low as 50% of their historical norms. And many pediatricians that I've spoken with have expressed concern that this reduction in care, even for well-child visits, but especially for complex care, could have long-lasting ramifications for pediatric health. On the next slide, you'll see the actual and projected impact on migration towards telehealth visits, which have had a profound impact on ambulatory operations. These visits initially spiked in late March before ticking down, and many organizations we've spoken with report virtual visits remain well above historic norms. The longer the pandemic goes on, the more complicated the payer guidance on telehealth has become, particularly regarding what the payer will cover or reimburse. Back in April, many payers committed to covering these visits at parity with in-person visits, but we've already seen that evolve, and Steve, I'm sure, will cover that in a little bit more detail. Long-term, we expect payers will pull back on the number of allowable services, implement some type of utilization controls, and reduce reimbursement for virtual care. But the basic truth is that virtual care is not the same as in-person care. Provider time commitment is similar, but they don't carry the same practice and facility costs, so we expect reimbursement will ultimately adjust to reflect that. Moving on to slide 9, I want to highlight here a downward trend that really we've seen consistently since 1990, but has become more dramatic over the last decade, a downward trend in birth rates, and experts are projecting an even more pronounced decline stemming from COVID. So what does this mean for pediatric hospitals and health systems? Systems are going to greater lengths to differentiate their strengths from the market. Building and branding institutes for pediatric heart, neuro, ortho, and cancer are all very common, and investing in new facilities and towers to increase as well as investing in new facilities and towers to increase capacity. We've seen continued regional consolidation since many smaller systems cannot muster the critical mass to keep their subspecialists busy enough to be financially feasible or clinically experienced. And this move towards a hub and spoke delivery model was only enhanced by the widespread adoption of virtual visits. And finally, on slide 10, as if all that we've already covered wasn't enough to cause medical group administrators to throw their hands up in frustration, we are preparing for the Medicare fee schedule changes, which will impact E&M codes and add-on codes. Now, this is where it gets a bit tricky. Some of the other meaningful changes are still in the proposal or vetting stage, which makes gauging their projected impact even harder. But if RVUs are fundamentally increased, as we expect they will be, we fully expect the conversion rate to be decreased in some manner to keep the cost neutral for CMS, and we fully expect commercial payers to eventually adopt those changes as well. And so with those introductory slides behind us, I'll now turn it over to Steve to discuss ambulatory care and digital health.
Thanks, Clark. It's a great introduction, and really what we've seen from those slides is now more than ever, we need to be focusing on patient access. So we still think of patient access as we always have. It's getting the right patient, the right provider, and in the right setting at the right time. And now using the right medium is more of an emphasis, right? So it's more than just getting them into the office as quickly as we can. It's also, do they need to come into the office, or can they use some sort of virtual platform? When we look at pediatric access, we typically look at it through 6 different lenses, as you can see on this slide. You have your care model and resource deployment. So are you using your NPs and your PAs well? Are you looking at team-based care? Do you have the phone and virtual access pathways that we need to have patients looking at? Do you have the contact center in place, a patient portal, other ways to connect to your care team rather than just going straight into the office? We also look at referral management. Is referral management centralized? Do we have the prior authorization, the verification, the insurance coordination? Is that all down so that the patient family can have the visit, conduct the visit, and not worry about the financial things that are happening in the background? We're always looking at the provider work standards in terms of, are providers meeting their contractual obligations? Are the office hours acceptable for patients? Can we offer after hours services, etc.? Within those hours, we're looking at capacity management. Is a Is the supply meeting the demand? Are we filling up those appointments that we have? Are we using clinic resources and exam rooms to the best of our abilities? And then finally, within that, we have the schedule optimization. Our templates maximized for access. Are we using the EHRs to the best of their ability, using those rules and blocks and making sure that we have an open access strategy so that we can get patients in the right manner. On slide 13, we've seen that this hasn't necessarily, the basis of access hasn't changed, but there have been some big impacts from COVID-19. In the spring and summer, we saw a huge increase in telephone volumes across all organizations, and pediatric organizations were no exception. In fact, some of them were hit even harder. In speaking to a lot of our pediatric colleagues, we've heard of phone volumes going up by 3 or as much as 4 times in those early weeks in March, April, and even May. We saw that the organizations that have centralized services were able to handle this a bit better, although most people were drowning from phone volumes and patient portal volumes just from the sheer amount of clinical questions, care navigation, and just questions about when can I have my well child check, how can I get my kid in for immunizations, etc. There's also decreased capacity, and there continues to be decreased capacity, whether it's state mandated or organizational based. We've seen practices say that they can't see as many patients per hour or per day for clinical restrictions. They don't want to have full waiting rooms, and they want to make sure there's proper time in between patients to be able to sanitize rooms. So this has put some squeeze on practices and providers to meet volume targets, to meet RVU targets, and also to be able to keep up with access. If we're seeing fewer patients per day, that wait list is going to get longer and longer. And finally, there's been a desire for safe visit. Of course, we want to make sure that the safe kids are staying in the safe clinics, the healthy clinics, and that those with symptoms are not being exposed to even more symptoms. So there's been this endless navigation of having COVID exposure clinics, of safe clinics, of well clinics, etc. And of course, that has pushed us to virtual care, which we'll talk about in a second. So on slide 14, I want to introduce, we think that it's probably best to talk about this through case studies. So the first one we want to talk about is more specific to patient access. On slide 15, we introduced this organization. It's a large organization based in the South. It has an affiliation with the university that has sometimes a tenuous relationship that has caused some impact on operations. Prior to our engagement, the system hadn't had a standardized approach to scheduling, templating, evaluating capacity or access, and patients and referring providers were dissatisfied by this. There were long wait times, things weren't clean, it was hard to get through on the phone, etc. So we looked at 3 different ways to solve this: through provider capacity, through access optimization, and through referral planning. I'll start on slide 16 with provider capacity. So as I mentioned earlier, provider capacity has been especially tough in COVID, and this was a great example of how to try to tackle that. What we did was we compared patient-facing time, patient demand, provider productivity, and patient access in one data set. We said that while there are some specialties that might be meeting all their RVU targets, maybe they aren't getting the patients in soon enough, or maybe they are getting their patients in soon enough, but they're underproductive or not meeting patient satisfaction scores. So we were able to plot this all out and prioritize the high need programs. You can see in the graph on the right that we were able to plot this out and have target intervention areas based on the size of the practice, based on the average days to new patient appointment and the RVU per CFD. So you can see some of those red dots in block 4 were the ones that we wanted to target quickest. They were underproductive and they had wait times of up to 2 months. Using this, we found some pilot clinics to work with, and we said, if we can fix these clinics, we can fix anyone, right? So these were identified by the physician leaders, and we said, we're going to pilot our access optimization initiatives and be able to tackle our plans to be able to see patients sooner, see patients in different ways, and allow patients to use the portal and online scheduling more effectively. Because of this, we were able to identify the clinics, and in these clinics, we were able to increase their session duration by up to 81% in some of their templates, just by looking through their templates and coming up with design standards. We'll go into that a bit more in the next slide. Finally, we also created policies and procedures around provider templated time going forward. So even for the practices that we didn't necessarily go in and have a more comprehensive pilot program for, we said, based on your contract, here are the minimums of templates. And just from that, we were able to see a few percentage increase in templated hours and in patients seen across the entire organization. And this has a profound impact when we're talking about what Clark was bringing up with the decreased visits, and then also what we were talking about earlier, where as we have decreased capacities for clinical reasons, we need to have more ways to get patients in. On slide 17, we talk about some of the pilots that we did. So we piloted two full-scale pilots in this organization, where we looked at everything from scheduling workflow redesign, template optimization, staffing, referral processing, even online scheduling and portal usage. A couple examples here on the left is we looked through the templates and we said, when are providers in clinic versus when are staff in clinic, and when are exam rooms available? What are we blocking patients for? How many patients are we seeing per hour, etc. So we were able to agree to increase session length to 4 hours to make full use of provider time, and to be able to make sure that, for example, after school hours, we had plenty of appointments available, and maybe in the early morning before parents were going to work, we had appointments available. We removed new patient limits and follow-up blocks so that we could have an emphasis on seeing all the new patients we possibly could to be able to drive volume and revenue into the system. And finally, we level loaded overbook slots throughout the session so that we were decreasing some of the wait time and some of the log jams that were happening at the beginning of the clinic. From doing this and from doing all of the other exercises we had in this access optimization pilot, we were able to add over 160 new slots per month for each pilot program. This increased provider utilization by over 10% in just the first 4 months that we were working on this after go live. We expanded the session duration for about half of the provider templates, and we were able to implement online scheduling because of the simplified templates. Before, they were a little too complicated and epic to be able to switch on open scheduling, but by doing this and by simplifying and standardizing templates, we were able to switch on online scheduling, and now patients have been able to schedule their appointments online, which has been especially helpful as telephone volumes have increased, and we've seen a backlog of some of those phone volumes, and people just want to have some self-service. Finally, we saw an immediate decrease in time to new patient appointments because of these metrics that I mentioned before, and we were able to expand this optimization work to additional programs because of the success that we saw here. Now, about a year later, we're seeing these changes roll out throughout the organization, and we've seen these as precursors to success in navigating these COVID-related issues that we've talked about. By having online appointing available, by having increased capacity, and by having more convenient times that can also allow for video visits, we've seen that this upfront work of optimizing templates and optimizing patient access has been a proactive response to the pandemic, while most organizations have been struggling to react to it. Finally, on slide 18, I'd be remiss to not mention referral planning. Even though referrals have not been as directly impacted by the pandemic as some other operations, it has remained extremely important to make sure that we have a sound referral process so that those referrals that do come in, we can capture those patients and capture that business. We set up a plan, as you see on the left. This is just one very small example of how we can centralize and optimize the referral process for the organization. The plan here is to be able to have all incoming referrals, whether they're faxed, whether they're called in, or whether they come in electronically, go into a central area so that those centralized agents can navigate the patient and schedule the patient centrally so that they can have a white glove experience and be able to go where they need to go, and also be able to understand the mediums in which they can be seen. By having them seen centralized, we've been able to push the patient portal more, we've been able to push the virtual visit options more, and we've been able to really push telehealth as much as we possibly can. This process is being implemented now, and it's been a wonderful response to the COVID pandemic, and we've been able to see that by having this team, we've been able to capture some of these patients that may have otherwise been lost in the system. So overall, this organization that had been struggling some with patient access decided to take a step back and understand where are we hurting the most and what can we do to alleviate that pain the best. By making some of those infrastructure changes, we saw immediate impact in those pilot clinics, and those immediate impacts rolled over to the pandemic wonderfully, and they were able to stay ahead of the pandemic's harshest impacts administratively and be able to remain scheduling patients, seeing patients, and keeping patients safe throughout the pandemic. The next case we want to talk about on the next slide focuses a little more on digital health and how do we set up a digital health program at a large organization. On slide 20, we want to introduce the system. We partnered with a large health system that's both pediatric and adult to design and implement a telehealth strategy to help them stay competitive in the market. This is a large health system with 6 hospitals. They were facing heightened competition in the market, and they were having some tighter margins and a lot of barriers with patient access and evolving patient preferences. On the next slide, we started off with the planning mode. First, we met with the stakeholders to understand what did they want out of this? What is digital health to them? And what do they want to offer their patients? What's the roadmap? We identified the technology solutions that were in place now that were being built or being bought, and we came up with a more standardized technology stack so that we could be strategic about what technology we were offering to the patients and what technology we could use for what type of visit or interaction. Finally, using all of this data, we worked with the steering committee and the physician leaders to come up with a roadmap and come up with analyses to develop a staffing and technology model to be able to say, this is where we want to start and this is our long-term vision. On slide 22, we show that vision. So what this organization ended up doing was starting small and going very big. We started with a simple e-visit program that was offered just to the employee health plan, just to get their toes in the water and to be able to say, you know, we can do this, we can make digital health work in the provider's eyes, and we can roll this out. At that point, they rolled it out to the entire patient population, and then they pushed out to on-demand video visits that were hosted through MD Live. At this point, we were going from asynchronous to live visits, and we're able to have enough provider capacity to host these visits and see patients, both pediatric and adult, on demand. When we were comfortable with that, we rolled it out to scheduled visits that we were seeing across both primary care and specialty care. And then after about 6 months of this, when we were comfortable with where that was, we started being able to sell these capabilities to local employers. So some large employers in town ended up contracting with this health system to have them be their exclusive digital health provider, such that if an employee of one of those industries were sick or wanted to see a provider, they could use the app and see a provider from this health system, or have their child see a provider from this health system, scheduled or on demand for a flat rate. Finally, this was moved. They moved their strategy not only from sick patients, but also to wellness, adopting remote patient monitoring and digital care management. So by the end of this about 2-year rollout, they had a very comprehensive digital health strategy and plan that was offered to a large patient population. The great part about this was the end of this timeline happened to be before COVID hit the United States. And so they had this infrastructure ready, and they were more than any organization that we've worked with or that I have personally worked with, they were as ready for COVID as you could possibly be given the circumstances. When Clark showed the graph earlier about how digital health skyrocketed in the last few months, this was of course true for this organization as well, just out of pure necessity, but they were able to do it in a more seamless way because they had the infrastructure, they had the processes in place to be able to push that forward. On slide 23, we can see the results of this. These are pre-pandemic numbers. They were seeing 300 telehealth encounters per month, which now sounds kind of laughably low, but in pre-pandemic numbers, this is a very high number, and they've been able to expand this by quite a few times, as other organizations have. What was great about this was almost 100% of patients received care within 1 hour, and they had almost 100% of patients saying they received their expected level of services and they were happy with it. Their net promoter score was 95% after a year. And something that I really want to touch on is about 60% of patients in a post-visit survey said, had this application not been available, they would have gone to the urgent care or the emergency department or a walk-in clinic. What's important about this is in the eyes of COVID is, of course, right now, no one really wants to go to the emergency department, right? I mean, we never do, but especially now when that can be a hotbed for the pandemic, we've seen this is a great way to avoid these sick clinics. And so having that infrastructure of digital health has been able to keep patients safe and keep patients away from where there might be exposure to the disease. So in sum, we've seen a lot of access measures and initiatives being pushed to help us avoid some of the concerns from the pandemic. And we've seen digital health really be pushed. We've seen the financial impact of digital health that has so far been here to stay and will hopefully remain here to stay. We've seen the operational impact of having those solutions here. So that's that for access and digital health. I'm going to turn it over to Evan to talk about hospital physician integration.
Thanks, Steve. So this is not a new trend, but certainly one that has been ongoing, and we continue to hear from organizations year after year that for a children's health system to really thrive and succeed, you have to have a really strong and integrated relationship between the hospital and between their physician practice. And there's still a number of organizations, if you look on the kind of the simple visual on the left, where the faculty group practice has been either embedded within the School of Medicine or more closely aligned with the School of Medicine, and then through an affiliation agreement and other contractual relationships, their services are provided to the Children's Hospital. And while they have a working relationship and often an exclusive relationship, these relationships are often plagued by really burdensome contractual structures, sometimes, 80, 90, 100 different contracts for every subspecialty service that are on different life cycles, different mechanisms, no clear delineation between clinical support and academic support, and eventually they start to buckle under their own weight, where so much leadership time on both the school and the hospital are dedicated to maintaining these contractual relationships that it really draws focus away from what should be the external strategies that we take to grow our enterprise. And so we continue to see an interest in how do we better align and integrate the faculty group practice into the children's hospital to really form and live as a children's health system. And for reasons that span working together on operational initiatives, having both the hospital and the physicians at the table to go out and negotiate deals in the region or with other health systems, to go to payers with one voice and think about new contracting products that really rely on both high performance with the hospital and the physician enterprise, and even to some extent to achieve cost efficiencies if there's duplication in practice infrastructure between the hospital and the practice. So on 26, for all these reasons, we see a number of different models that organizations have explored to better achieve this integration structurally. On the left, kind of the most simple and streamlined version is to have a pediatric practice as an entity within the health system or within the children's hospital, so that it doesn't disconnect the practice from the university. They still have their faculty appointments through the School of Medicine. The chairs and chiefs still have reporting lines through the dean. But on matters of the clinical enterprise, those decisions are being made through the practice and through the hospital collaboratively. In the middle, the PSA or lease model is a common alternative to direct employment or dual employment. And in this, it allows the physicians to remain employed through the School of Medicine, but through a global arrangement, replaces kind of the bundle of individual contracts and really has the physicians working in kind of an employment light structure through the children's hospital. And these models are common often in states with corporate practice of medicine laws, where the physicians cannot be employed through the hospital, or state institutions where there's or even private institutions where there is a employment or benefits rationale for having the faculty still based within the school. But for matters of clinical, again, the decision making here and the operations really almost mirrors what direct employment might look like. And then thirdly, less common but still utilized as a true joint venture practice with a new entity with two corporate parents, the university and the hospital, where both populate the board and share governance responsibility. And then the model defines how the financial resources associated with the practice, how the funds flow works between the hospital and that JV. So there's no model here that's necessarily better or worse, because they're all tailored to the situation. And I think there's probably unique flavors as you go and look at different children's hospitals, but inevitably the trend has been towards more integrated relationships on the clinical enterprise, with still strong academic affiliation arrangements and commitments to the academic mission, regardless of structure. On 27, we just reflect back in kind of what has led to this and what to think about in your own organizations. But it's just becoming increasingly more complex through reimbursement systems and other models to have a siloed hospital and physician enterprise. So these transitions have been steadily occurring to try and break down some of those barriers. Obviously, to be successful at making such a transition, it needs to be a strong partnership with the university. It shouldn't be interpreted as a hospital takeover, because inevitably all three organizations have to be healthy and have to be successful for the health system as a whole and the academic enterprise to be successful. And so, that includes, commitments around GME, around mission support and ongoing investments in the research enterprise to make sure that they are as healthy and strong as the clinical enterprise as well. With corporate structure, that can certainly remove some of these silos, but the parties still have to agree to function differently oftentimes, and there's a wide range of outcomes depending on the functional integration that is set up in the design, regardless of which of those models is ultimately selected. And I think this speaks to even in organizations that may have a hospital-based physician organization, there's oftentimes quite a bit of improvement that could happen from a functional integration standpoint. And lastly, these transitions really are predicated on the belief that the Children's Hospital needs strong physician leaders as a partner with them at the table, whether it be with other children's hospitals that you might want to partner with, other adult systems, go into payers. And so, this provides an opportunity to really elevate physician leadership in the health system. If we keep going on 28 and into 29, a more emerging trend that we continue to see a lot of activity and discussion on the market is hospital-to-hospital partnerships in different flavors between freestanding children's hospitals, between hospitals within hospitals, so pediatric facilities that are embedded within adult hospitals. And I think some of the drivers for why this activity is picking up are around as Clark mentioned early, flat or declining populations in many markets once you get out of the major metro centers that make it really challenging to sustain specialty and tertiary programs. The need for pediatric subspecialists and the ability to recruit everyone that you need to support a comprehensive program has become very challenging, and those providers want to work in big academic centers oftentimes, and so in medium markets or small markets it becomes very challenging to keep them if you can even get them to begin with. The economics of small pediatric programs, especially with high Medicaid payer mixes, is very challenging. And then the opportunity to partner with another organization, a bigger children's hospital, and leverage some of that brand strength is an imperative for partnership. On 30, the spectrum of options historically that have been used in partnerships has kind of been on the end of this. So maybe coverage arrangements or staffing agreements, PSAs for specific services, and then maybe really integrated models, just acquiring a full hospital. But there's a lot of appetite for something in the middle that's more integrated with shared financial risk and reward, but that isn't as far as a full acquisition or shutting down a program. And so organizations are looking on 31, I think in particular, on some new models that can be utilized to think about how can we come together in a more integrated relationship that allows us both to benefit and to survive, but do so in a way that's more efficient. And so on the left, a joint venture physician organization where the specialists are in one manner or another working collectively to service two different facilities allows you to address some of the recruitment issues and potentially some of the lower volume issues that lead to economic inefficiency, and provide more coverage and support so that you don't have issues when you have a departure or retirement. A joint operating agreement, or sort of a virtual joint venture or service line joint venture that lets two different organizations pool their collective revenue and expenses for their pediatric programs in a way that doesn't change the licensure or the branding, but lets them begin to work more collaboratively and be financially integrated to make decisions in the best interest of the collective enterprise rather than their individual organization. And then lastly, a management services agreement, where typically one smaller partner might turn the keys to their program over to another larger partner and allow them to manage that program and take on more of the financial risk for that program, but still meet their service needs for the health system as a whole. And then lastly, on 32, as we think about these, for smaller programs, we know that there are a lot of risks associated with that and with poor outcomes or with physician dissatisfaction. And so that is pushing people to think about new partnerships. I think there's also some dissatisfaction with some of the service agreements or contractual agreements with big freestanding children's hospitals that are often expensive and maybe not at the levels of service that an organization would hope for, but acknowledging that many adult systems with pediatric units need to be in this business, need to support a women's program, and need to figure out a way to do so efficiently so that they can continue to be viable and grow rather than having to sort of sell or shut down. So with that, I'll turn it over to Angie to talk about the results from our 2020 pediatric survey.
Thanks so much, Evan. So in addition to our work with children's clients in compensation planning and ambulatory health and system-wide digital health strategies and in academic integration and partnerships, one of the ways that ECG has partnered with pediatric clients to ensure they have the relevant data that they need to manage the clinical enterprise is by producing our dedicated pediatric survey. So it really serves as a tangible way that we help organizations understand the compensation and productivity landscape for the pediatric market. Participation is free, and so are the results and the benchmarks for everyone who submits data to us. So I thought it would be helpful to spend just a minute going through some of our high-level findings and then talk through some of the key data elements that we collect in the survey. So on slide 34, in 2020, we reported specialty-specific data for over 7,000 pediatric physicians across 115 organizations. A vast majority of these physicians are employed by a hospital, health system, or academic entity, basically just not in an independent group. And that really mirrors what we're seeing in the larger market with respect to employment trends as well. The typical survey respondent, if you look at some of their other demographics, about 68% of them are affiliated with freestanding children's hospitals, and about half of the providers in our survey do practice within some sort of academic or teaching hospital environment as well. Moving on to slide 35. Our data set does represent a national pediatric market with physicians practicing coast to coast. And this year we were able to report data in 41 of 50 states. The ECG data can be filtered using a variety of demographic attributes. Region is one example of the ways in which we cut the data and aggregate some of our findings that we publish. We also have the ability to produce compensation and production benchmarks along other key demographic factors. One would be a cut of teaching versus non-teaching. And then within that teaching cohort, we can also array and align the data by faculty rank rank as well. We also look at it by ownership status, by the size of the organization in terms of the number of physicians. So less than 75 physicians versus say, 75 to 150, 150 to 250, that kind of thing, to give an idea of how the different benchmarks may vary based upon the size of the organization in which the physicians are practicing. Just to give you an idea of when we look at compensation by region, we do find that physicians in the West are generally the most highly compensated when we split our specialties that we report into hospital-based, medical, surgical, and primary care. Those physicians in the West do have the highest average compensation in 3 of the 4 specialty categories, while physicians in the East generally have lower levels of compensation in all of those categories on the left, except for primary care. All of the data in our survey is reported by pediatric subspecialty. We publish benchmarks by metric and by specialty where we have at least 5 unique organizations that are within that cohort. In 2020, we reported benchmarks across 50 unique pediatric physician specialties and 6 types of pediatric APPs. So in addition to our 7,000 pediatric physicians, we have close to 1,500 advanced practice providers that are pediatric focused. And these would include providers like your nurse practitioners, your surgical and non-surgical PAs, psychologists, neuropsychologists, audiologists, and any of those non-physician providers that work with kids. Moving on to slide 36. Each year we do a detailed analysis of market trends. We collect a comprehensive set of compensation as well as productivity data. And then we're able to compare the results from our prior year survey to what we're seeing this year. And we think that's important because we're able to then look at just the same organizations and same physicians that were in our data set last year to this year. And then we're able to aggregate and look at the trends within those physicians year over year. And we feel like that creates a good comparison of what's happening within the market. So overall, between our 2019 and 2020 survey, we saw compensation increase by 2.4% across all pediatric physicians. This number has been fairly stable in aggregate over the past several years, as indicated in the table on the right. However, we do see larger variability at the specialty level. So in addition to tracking these metrics in aggregate and by specialty category, we actually can get down to the specialty level as well. With respect to RVUs, after a small increase last year, this year work RVUs were relatively flat when we compared them to prior year, with a lot of variability again at the specialty level. When we looked at medical specialties specifically, they were the only group of pediatric physicians where we saw a slight increase in their work RVU production year over year, and their work RVUs increased by 1.7% compared to last year. Physicians in hospital-based specialties, surgical specialties, and primary care pediatrics saw either small decreases or flat work RVUs when we compared them to prior year. One unique attribute of ECG surveys is that our work RVUs are derived from CPT data. So instead of requiring that self-reported RVUs are what we expect to have our participants submit, we ask them to submit their CPT codes by the rendering or service provider. And then we calculate those work RVUs and total RVUs for every provider in the survey for which we have data. And that allows us to do some unique things with our CPT codes and really helps inform a lot of different analyses that we do. One of the more relevant things recently that we've done is with respect to the physician fee schedule for 2021. So As you all very likely know, the changes to the 2021 physician fee schedule were finalized last week, and it really solidified the significant changes in RVUs specifically for E&M visits. The rule, of course, had dozens of changes that we expect will be implemented in 2021, but the E&M visit one is the one that will most significantly impact the RVUs at your organization. So specifically, work RVUs for established patient visits, so that's your 99212s to 99215s, are increasing significantly, anywhere from 28 to 46% over the current levels. And because we do collect that CPT code level data to calculate RVUs, we're able to apply any fee schedule and any RVU changes to see what would be the overall impact. So we were able to generate what the new work and total RVUs would be utilizing our survey data set under the now finalized 2021 rule. And what we found is that when we compared the finalized 2021 work RVUs to our baseline year, that work RVUs for your same volume is going to increase between 8 and 15% overall. The 8% increase would just be applying the new work RVU values for those E&M codes, and the upwards of 15% would be applying the new work RVUs for E&M codes plus adding assumptions around how the add-on codes will be billed. So that's your GPC1X codes and whatnot for add-on codes. Of course, because E&M visits are more heavily concentrated within your medical specialists and primary care specialists, that's where you're going to see the largest impact. Our primary care RVUs are expected to increase anywhere between 13 and 25%. So I urge you, if you haven't yet done that analysis, to understand how your RVUs are going to change under the now finalized schedule, please reach out to us. We're actually offering to conduct that analysis for everyone on a complimentary basis, and all it requires is that we have your CPT codes in order to run that analysis. So that was a bit of a diversion, but I thought it was important to point out since that final rule was just issued last week. So moving on to slide 37, I'd like to talk through a little bit of the benefit data that we collect as well. So in addition to compensation, we report on the cost of benefits in total, and we also have several benchmarks for key benefit components such as retirement, CME, and other benefits as well. And this year, what we saw is that for physicians, the average benefits were relatively flat compared to 2019 at $50,637 for physicians, and the benefits for APPs in our survey increased a little bit to $28,653. We do have this data at the specialty level in our survey as well. When we look on slide 38, this really summarizes our key findings around the data elements that we capture on fixed versus variable compensation. So the proportion of total compensation that is variable has trended upward in each year that we've collected and reported the data. In the 2020 survey, the overall average percent of compensation that's variable or at risk is 37.9% for physicians and 8.7% for APPs. On slide 39, this dives a little bit more into the various components that are driving those compensation plans. 79% of our survey organizations say that work RVU production is a component in the compensation structure for their physicians, and 58% of those organizations incorporate work RVUs into compensation plans for their non-physician APPs. Work RVU incentives account for about a quarter of total compensation in these organizations, but only 1.5% of total compensation for APPs. We also have a significant proportion of organizations that are capturing quality or patient satisfaction measures. And even though we do have, 57% for quality, 18% of organizations have some sort of patient satisfaction measure, in aggregate, those variables still only derive about 5% of total compensation. So we do see that number continuing to grow, but it is not yet a significant proportion of total compensation for physicians or APPs. Slide 40 highlights one of our specific findings around the clinical quality incentives. We did have more physicians than ever before this year actually report data to us for this metric. Nearly 40% of those physicians provided clinical quality compensation for the 2020 survey. And for these physicians, all of them, their median compensation for clinical quality was $16,276. Because we do track this over time, we also can look at last year's data set and this year's data set and compare who are the physicians who have earned quality dollars in both years of the survey. And that's actually the third and fourth set of bars in this slide here. And we can see for those physicians, for physicians earning quality compensation in both years, it has gone up both the median and the average. The median for those physicians is $16,273, and the average is quite a bit higher at $25,426. So that's just an example of some of the detailed information that we do have available in the survey. I believe that I'm going to wrap up and end on that note. And if I can turn it back over to Clark, we might be able to take a question or two from the audience.
Thank you so much, Angie, and thanks, Steve and Evan. We packed a lot in here, so like you said, we probably only have time for one or two questions, but like we said, if we don't get a chance to address your question, please go ahead and type it in, and then we can connect with you offline. But in the interest of time, I'm going to just jump right in here. We did get a question at the end of Steve's section specific to kind of navigating some of those state regulations, so let me read it. What was your approach for handling the patchwork of state regulations when crossing state lines? Even with the PHE waivers, there are limitations on being able to see new patients via telehealth depending on state regulations. That was actually a thought I had as well. So Steve, I'd love to hear if you guys encountered that.
Yeah, it's something that we've encountered and actually encountered pre-pandemic with telephonic nurse triage. That ends up being, it's a very state-by-state regulation. And so it's obviously important to have your medical directors work with the state legislatures. What we have found to be effective is typically if patients have established care at an organization and have their home address in the state where the organization is, you can usually justify being able to treat that patient without having to ask, where are you physically standing right now, et cetera, et cetera. But of course, I am not a lawyer, so I definitely recommend making sure that you get your compliance team in touch with your clinical team to make sure that you're following these new and sometimes lasting regulations. So I'm sorry I couldn't be more clear about that, but yes, it can be tricky, but it usually states can have some flexibility in there.
Thanks so much, Steve. I think just in the interest of time, we'll go ahead and cut it off there. I do want to, first of all, thank everybody for their attendance today. We had great attendance, especially coming up on the holidays. We always know it's a little bit challenging to make room. So again, thank you all for attending today's presentation. If you do have any additional questions or comments, please don't hesitate to reach out to one of us via the contact information provided in the handout. And I'll just say one final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey. Upon exiting today's program, as stated earlier, ECG will make a $5 donation to Doctors Without Borders for each of those surveys submitted. And the last thing I'll say just here in the last 30 seconds is if you attended today, and this was a bit of an introduction to ECG, and you are interested in participating in our pediatric survey, like Angie said, it is, we believe, the most robust pediatric survey on the market. It has a really compelling blend of academic and non-academic participants, and it's something that we can help you modify and really kind of turn from data to information to something very actionable for your organization. So if you are interested in joining our survey in the upcoming years, please don't hesitate to reach out to Angie or myself, and we would love to have your organization participate. And with that, I will say again, thank you for joining us today, and have a wonderful holiday season, and hope you join us for our upcoming pediatric surveys, which will be scheduled in the new year. Thank you all.